Good morning, ladies and gentlemen. Thank you for joining me today. My name is Joanna Bergeres-Tilita, and I'm an anesthesiologist in Bern, Switzerland. I would like to thank the organization of the International Scientific and Practical Conference of Psychology of the Living Space of the Individual in the Current Conditions of Crisis, Globalization, and Digital Transformation of Public Life for the kind invitation to be here today. And I'm going to talk about a critical issue of the healthcare industry, which is the professional burnout syndrome. These are my conflicts of interest. And I am going to start by talking about the definition of professional burnout syndrome, or PBS. It's a state of physical and emotional exhaustion, often accompanied by feelings of depersonalization and reduced personal accomplishment. Burnout is now included in the 11th revision of the International Classification of Diseases, and it's classified as an occupational phenomenon. It's not a medical condition. The term burnout in psychology was coined in the late 70s, so it's a relatively new diagnosis, and it's defined as resulting from chronic workplace stress that has not been successfully managed. It is characterized by three dimensions: feelings of energy depletion or exhaustion, increased mental distance from one's jobs or feelings, or negativism related to one's job, and reduced professional efficacy. Unfortunately, this phenomenon is increasingly prevalent in healthcare. Many studies report high levels of burnout in doctors, with psychological morbidity ranging from 19 to 47%, compared to a rate that was around 18% before COVID, and that now is around 52% for the general employed population. For primary care doctors or general practitioners, most studies report a moderate degree of burnout, especially for the emotional exhaustion dimension. Anesthesiologists, which is my case, also have moderate degrees of burnout, with a high job satisfaction moderating the negative effects of stressors at work. However, the literature is inconsistent in which medical specialty has the highest percentage of burnout, but we know that after COVID, the frontline healthcare workers have shown consistently a very high degree of burnout. Burnout does not occur only in healthcare. The occurrence of burnout syndrome is diverse, as in social workers, advisors, teachers, nurses, speech therapists, police and prison officers, or even housewives, students, or unemployed people. In most of these occupations, the combination of caring, advising, healing, or protecting, coupled with the demands of showing that one cares, is of central importance. There are several studies discussing the occupational, psychological, and psychomental stress factors for burnout. These include pressure of time, overtime, shift work, lack of autonomy or mobbing, an economic pressure, and juggling multiple tasks such as job, family, and leisure activities. In addition, the pressure of performing well in non-technical skills is continually increasing, and this need for communication and being able to work well as a team, to have a high frustration tolerance and flexibility also seems to play a role. So why does burnout happen in healthcare? The stressors and challenges healthcare practitioners face make them particularly vulnerable to burnout. Long hours, high patient caseloads, and strain are common, not to mention the recent COVID-19 pandemic. And the climate in medicine is also changing. There is a production pressure that leads to less doctor-patient contact time, an increase in paperwork, a trend towards managed care, reduced government spendings, and diminished physician resources. At the same time, patients have become more strenuous and demanding, have higher expectations, and no longer have the same respect as they used to have for doctors. All these factors contribute to lower job satisfaction and can cause a decline in autonomy and control in doctors, leading to higher risks of burnout. Burnout in healthcare has far-reaching consequences, impacting both practitioners and patient care. Burnout symptoms include cognitive challenges like poor concentration, memory lapses, and also personality changes, such as reduced motivation and aggressiveness. Physical symptoms include headaches, gastrointestinal issues, and cardiovascular problems like tachycardias or arrhythmias. In severe cases, burnout can lead to anxiety, depression, and even suicide. Healthcare professions often develop substance abuse tendencies, turning into alcohol, drugs, or medications. Nearly 10% of them may develop substance-related disorders. This is because they have access to pharmaceuticals. Usually they self-medicate, and all of this can increase the risk of addiction. Socially, burnout results in a workplace withdrawal, relationship difficulties, and isolation. But the consequences of burnout extend beyond the well-being of practitioners. They also affect patient care by reducing empathy, increasing medical errors, and diminishing patient satisfaction. Now let's talk about the strategies to mitigate burnout. There are several levels of intervention that can be divided into primary preventive measures, secondary measures related to early recognition, and tertiary measures, which has to deal with coping with the consequences of the diagnosis. Psychotherapy is the use of psychological methods that you know much better than I do, with the aim of reducing psychological symptoms, treat mental disorders, and learn new coping skills. Examples of effective psychotherapies in burnout are cognitive behavioral therapy, eye movement desensitization and reprocessing, the EMDR, and acceptance and commitment therapy. Psychotherapy seems to be the most effective in treating burnout, both in the reduction of burnout symptoms and also in the prevention of burnout. Some interesting facts about it is that individuals with burnout who underwent 14 cognitive behavioral therapy sessions had significantly reduced cortisol levels compared to those without treatment, and that cognitive behavioral therapy has reduced the subjective complaints and improved general health. However, the cognitive performance on tests did not improve after cognitive behavioral therapy. Other interesting therapies that we can use is, for example, mindfulness, which is also effective with studies showing that is reducing burnout symptoms by about 60%. And other potentially effective psychotherapies include music therapies and stress management, spa treatments, art therapy, but obviously these are based on low evidence trials, and more research is needed to confirm these findings. Of relevance is that even though more than half of the people on sick leave due to burnout use psychotropic drugs like antidepressants or sleep medication, there is still no effective medication to treat burnout. I brought you here one very interesting systematic review and meta-analysis on physician burnout prevention and reduction strategies. And they're very interesting key findings and points of this study. So the literature suggests that there are several measures which include structural interventions within the work environment, attending rotation length shortening, modifications of clinical work processes, shorter residence shifts, and some individual-focused interventions like facilitated small groups, stress management, and self-care training and communication skills training. So both of these strategies, both individually focused and organizationally focused, seem to be able to reduce burnout among physicians. I brought you here a second study from the JAMA that recorded comparisons between studies involving around 1,500 physicians, which showed that organizational directed interventions were much more effective with a larger reduction in burnout compared to physician directed interventions. I also found this study very interesting, particularly because the audience is composed of psychologists. We have seen that the most effective measures are actually psychological measures, so cognitive behavioral therapy. But I found this study that shows that is very challenging to treat physicians with burnout. The study aims to understand the specific challenges in treating physician burnout and explore the origins of these challenges. This is a pure qualitative study conducted by 12 psychologists in France. And what they found is that there are two main challenges in treating physician burnout. First, physicians are reluctant to seek help from health professionals and often do so only at more severe stages of exhaustion. And physicians feel uncomfortable in the role of a patient and have difficulty accepting treatment. The psychologists that did this study suggested several causes for the challenges. First of all, many physicians did not have a general practitioner themselves. Physicians felt guilty about reducing their workload, and they tended to blur the lines between their professional and personal engagement. So, and this is my final slide. In conclusion, professional burnout in healthcare is a pressing issue that seems to have increased in the medical community after COVID-19. We've discussed the causes, the consequences, and some strategies for mitigation. We have seen that it's not just a matter of individual well-being, it has also impacts on patient care and in the healthcare system as a whole. And I now end my talk. I would like to thank you for your attention today and send wishes of victory to Ukraine. And I'm now available for questions.